Ever walked past those ER doors and just felt that wave of intensity, like something big is happening? Well, today, we're like flies on the wall getting a backstage pass to thoracic trauma, those critical injuries to the chest. And we're going deep into Chapter 4, Thoracic Trauma Revision Notes, not to replace those textbooks, but to give you the highlights you're going to remember.
You know, what's fascinating about thoracic trauma is that speed is everything. When we talk about these injuries, we have a very systematic approach because some of them can be fatal within minutes.
Okay, so paint a picture for me. A patient arrives with chest trauma. What's the first thing that pops into your head?
The first thing we think about is tension pneumothorax.
And that.
That's where the lung is being squeezed, like a balloon.
Hmm.
The pressure builds with every breath they take. We call it the kill zone for a reason.
Okay, so what are some of those signs and symptoms, those red flags that tell you this is a tension pneumothorax?
So imagine the lung is being squeezed like a balloon. It's all about pressure, right? So you're going to see their veins in their neck bulging. They might be struggling to breathe. And one side of their chest might sound oddly quiet when you listen with your stethoscope.
Oh, wow. Okay, so every second counts in that situation.
Absolutely. You need to relieve that pressure, fast needle decompression, then get that chest tube in.
Intense. The source material also talks about open pneumothorax, also called a sucking chest wound. What's the key difference there?
With an open pneumothorax, think of it as a breach in the chest wall. Air is being sucked directly into the chest cavity, disrupting the normal breathing process.
So the lung can't create the right pressure to function.
Exactly.
How do you manage that?
So we need to seal that breach. And we do that with a special dressing, an occlusive dressing, taped on 3 sides. It allows air to escape, but not enter.
Clever. Now, shifting gears from air to blood, what about a massive hemothorax? What is that?
Essentially, it's a significant amount of blood filling the chest cavity, which compresses the lung and prevents it from expanding. So internal bleeding, but within the chest.
So would the symptoms be related to both blood loss and difficulty breathing?
Exactly. You'll see signs of shock, pale skin, rapid heart rate, confusion, low blood pressure, and when you listen to their chest, it might sound dull on the affected side.
Another situation where every minute counts. So what's the game plan there?
Same principle, relieve the pressure. We insert a chest tube to drain the blood and allow that lung to re-expand.
Got it. Okay, what about flail chest? That sounds incredibly painful.
It is. It's essentially when a section of the rib cage breaks in multiple places, becoming detached from the chest wall, which disrupts the normal mechanics of breathing.
And our source material mentions paradoxical chest wall movement.
Right.
What does that look like?
It means that the injured part of the chest wall moves inwards during inhalation and outward during exhalation, opposite of what it should be doing.
Wow.
Breathing becomes incredibly inefficient and often very painful, and usually signals an underlying pulmonary contusion.
Which is?
It's like a bruise, but on the lung. It can severely impair the lung's ability to do its job to exchange oxygen and carbon dioxide.
So with a flail chest, you're dealing with both a mechanical breathing problem and a lung injury. How do you approach that?
We focus on pain management to help them breathe better, provide oxygen therapy, and sometimes even use mechanical ventilation if needed.
It sounds complex. Okay, last but not least, we have cardiac tamponade.
This one is less common, but just as deadly if we miss it. Imagine the heart is encased in a sac, the pericardium. In cardiac tamponade, this sac fills up with blood or fluid, squeezing the heart.
So cardiac tamponade is like a pressure crisis, but this time it's the heart that's being squeezed. What are those red flags?
Think of it as the heart struggling to function under pressure. You'll see low blood pressure, distended neck veins, those telltale signs of pressure, and muffled heart sounds because the fluid is essentially muffling the heartbeat.
Wow. So similar to those other conditions, the goal is to relieve that pressure.
Exactly. We perform a procedure called pericardiocentesis, using a needle to drain the fluid from that sac surrounding the heart. Again, time is of the essence.
We've covered a lot of ground already. Feels like we've just run a marathon through the ER, but we're not done yet, right? Thoracic trauma, there is more to it than just those initial heart-pounding moments.
You're absolutely right. Stabilizing those immediate threats is just the first step. We then shift into detective mode to uncover the full extent of the injuries.
Like piecing together a puzzle, I imagine. Our guide, Thoracic Trauma, Revision Notes, highlights imaging and additional tests as those crucial next steps.
Precisely. We start with the trusty chest x-ray, our workhorse. It's quick and gives us a good overview, like seeing the crime scene for the first time. We can often spot pneumothorax, hemothorax, rib fractures, those key players.
But sometimes you need a more powerful magnifying glass. What other tools come into play?
If we suspect something's going on that we're not seeing, we turn to the fast exam-focused assessment with sonography for trauma. It's a rapid ultrasound that can quickly detect fluid around the heart or lungs.
So FST helps us see those more subtle fluid collections. And our source material also mentions CT angiography. That's all about getting a detailed look at the blood vessels, right?
Exactly. Let's say we're concerned about damage to the aorta, a common concern in a high-impact trauma. CT angiography gives us a 3D roadmap of those vessels, pinpointing any injuries with incredible precision.
Because even a small tear in the aorta could have devastating consequences later on.
You got it. It's all about connecting the dots, understanding the mechanism of injury, and using the right tools to confirm our suspicions.
So far, we focused on the more common injuries. But our notes also highlight some less frequent but still significant injuries. One that caught my eye was diaphragmatic injury. The diaphragm almost sounds too delicate to withstand trauma.
You'd be surprised. It takes more force than you might think. But blunt trauma from a car accident or a fall can definitely injure it. And sometimes even forceful coughing or vomiting, especially in someone with a pre-existing weakness, can cause a tear.
It's amazing how much force can be transferred within the body. Another injury that seems unexpected is esophageal rupture. What usually causes that?
This is usually associated with severe vomiting. Imagine someone who's been vomiting forcefully. That pressure can actually rupture the esophagus, the tube connecting the mouth to the stomach.
You don't often think about the force behind those everyday actions. And the last one on the list here, traumatic asphyxia.
It is. Imagine someone being crushed or pinned under a heavy object. That immense pressure on the chest restricts blood flow back to the heart. And you see this distinctive pattern of bruising on the face, neck, and chest as the blood is forced upwards.
So traumatic asphyxia isn't just about breathing, but the immense pressure impacting the circulatory system.
Precisely. And because it's caused by such extreme force, we always look for other associated injuries, cardiac problems, spinal injuries, head injuries. It's rarely an isolated injury.
Thinking about all of this makes me realize how easy it would be to miss subtle signs if you aren't incredibly thorough.
That's why a methodical approach is crucial for every single patient with thoracic trauma. We can't afford to miss a thing.
We're back with our thoracic trauma deep dive. We've navigated that kill zone, talked about those crucial assessments, but they say the devil's in the details, right? So what are some of those don't forget elements that can really make a difference in patient care?
It's easy to get caught up in the algorithms and protocols, but remembering that each patient is unique is crucial. What seems minor in one person could be a red alert in another.
So we're talking about individual factors here. What's a good example of that?
Let's take rib fractures. A single rib fracture in a healthy young adult, likely to heal well. Painful, yes, but not usually life-threatening.
But you're saying that changes with older adults.
Absolutely. With older adults, rib fractures, even from minimal trauma, can be much more serious. Their bones are more fragile, they might have other health conditions, and their risk of complications, like pneumonia, goes way up.
Makes sense, because if it hurts to take a deep breath, you're not clearing your lungs effectively.
Exactly. So, our approach has to be tailored to the individual. Age, health history, other vulnerabilities, it all factors in.
The art of medicine, right along with the science. What other seemingly small details can have a big impact?
Don't underestimate those basics like high-flow oxygen. It's a cornerstone of thoracic trauma management for a reason.
Back to basics. So why is oxygen so essential in these cases?
Think about it. What's the common denominator in most thoracic trauma? Compromised breathing, right? Collapsed lung, blood in the chest, bruised lung tissue. It all adds up to less oxygen getting where it needs to go. Supplemental oxygen helps us ensure adequate delivery and prevent further complications.
Got it. So even if someone's not visibly struggling for air, high-flow oxygen is still the standard.
Absolutely. It can significantly impact recovery, even if you don't see the effects right away.
Now, we've been talking about thoracic trauma in general, but our notes also highlight some specific considerations for different populations. Children, for example.
Kids, they're interesting because their bodies respond to trauma differently. They're actually more prone to lung injuries because their chest walls are more flexible. They might not break ribs as easily, but that force of impact can still be transmitted to those little lungs.
Interesting. And then on the other end of the spectrum, we have the elderly population. What makes their care unique?
With elderly patients, it's all about anticipating those potential problems. They're more likely to have pre-existing conditions, their bones are more fragile, and their physiological reserves, well, let's just say they're not what they used to be. We had to be incredibly diligent, especially with pain management.
because you don't want to mask any underlying complications.
Exactly. Careful observation, individualized care plans, and a healthy dose of anticipating potential issues. Those are key.
This deep dive has been amazing. We've covered so much ground, from those initial life-saving interventions to those subtle but crucial details that can make all the difference.
And the learning never stops. Thoracic trauma is a complex puzzle. Every piece is connected.
It's a challenging field, but incredibly rewarding, I'm sure. That's all the time we have for today. But listeners, here's something to think about. We've talked about recognizing the signs and symptoms of these injuries, but what if those symptoms are masked, hidden beneath other factors? It's something to ponder. Thanks for joining us for this deep dive. We'll see you next time.